or ASH to be involved in this meeting. I know we have had the pleasure of working with many Sickle in Africa colleagues over the past few years and really been able to see the great work that you all do for sickle cell disease in Sub-Saharan Africa. And we really look forward to our continued engagement together and our partnership in these efforts. So as shared, the American Society of Hematology, today's focus will be really on our sickle cell disease efforts in Sub-Saharan Africa. Our agenda for today is I'll give a brief overview of the American Society of Hematology, particularly our global programs, our sickle cell disease initiative that spans around the world. Talk a bit more about CONSA, or the Consortium on Newborn Screening in Africa. Dr. Chirande will then give us a nice overview of the Tanzania program, providing some more in-depth knowledge given her lead of the program. And then my colleague, Erin, Sheek, will present on the ASH Global Capacity Building programs that we offer as part of our mission. So again, as a brief introduction, so the American Society of Hematology, or ASH, has more than 18,000 members from nearly 100 countries. And we consider ourselves one of the world's largest professional societies serving both clinicians and scientists who are working to conquer blood diseases. And our mission is to foster high quality, equitable care, transformative research, and innovative education to improve the lives of patients with blood and bone marrow disorders. And again, part of that mission, as you note, is that our work is meant to conquer blood diseases worldwide. So we ensure that our programs not only just reach the United States, as we are the American Society of Hematology, but also can make an impact around the world in our efforts to conquer blood diseases. So a bit of a quick overview of our global programs. My colleague Erin will go more in depth in our capacity building programs, but our global programs really consist of three key areas. First and foremost is our research consortia, which includes our International Consortium on Acute Leukemia, primarily located in Latin America, our Children's International Consortium on Acute Leukemia that includes research in Latin America as well as the Caribbean, and then the Consortium on Newborn Screening in Africa, which I'll delve into as well. So these kind of three consortiums bring hematologists from around the world together to really focus on a specific blood disease and certain treatment protocols and so forth to conduct research to show the benefits or the abilities of certain protocols in providing care for blood diseases. And again, I'll delve more into cons in just a minute. Our capacity building programs, as already mentioned, include our visitor training program, Global Research Award, Health Volunteer Overseas, International Outreach Initiative. And our partnerships as well are really critical. We partner with numerous different hematology societies around the world to kind of share best practices, share research, and ensure that we are working together as effectively as possible, coordinating our efforts. And so always, as I've mentioned with the Sickle in Africa partnership, we look forward to continuing to grow as we implement our Consortium on Newborn Screening in Africa, as well as see the growth and expansion of Sickle in Africa as well. So about 2015, 2016, ASH decided to embark on a broad sickle cell disease initiative, knowing that there was a great need that we saw both in the United States as well as globally from this really orphan disease, if you will. So we kind of focused on 5 key areas to promote our sickle cell disease initiative, which include access to care, including the development of new sickle cell disease guidelines, expanded education and training for our hematologists and allied health professionals, as well as focus on sickle cell disease adult center workshops. Research from our ASH Research Collaborative, which is a sister organization of the American Society of Hematology, is really focusing on developing clinical trial networks, as well as a platform for learning and data collection as well for sickle cell disease. We do a lot of advocacy, mostly in the United States with our federal, with the Congress, as well as with our executive branch, really focusing on raising awareness on sickle cell disease, enhancing any federal or US-wide government activities on sickle cell disease, as well as improving reimbursement for care and treatment. We've also engaged in global advocacy at World Health Assembly events, as well as in different WHO events as well, to help support sickle cell disease awareness raising. And finally, we also are the Secretariat for the Sickle Cell Disease Coalition, which is a group of over 100 members dedicated to sharing information, collecting knowledge and resources, and then sharing best practices around sickle cell disease care, treatment, and advocacy as well. And then finally, with the global, our Consortium on Newborn Screening in Africa. So again, this is a brief overview of kind of our overall sickle cell disease initiative. More information is available at hematology.org. And I'm happy to share that information with you in the chat button on where to find more information on all of our different sickle cell disease initiatives. I did want to just quickly note, as I noted, we've really worked hard to develop new sickle cell disease guidelines in collaboration with our hematologists and other organizations. And here's just a list of some of the guidelines and resources we've developed over the past few years, particularly towards sickle cell disease. Again, my hope is to be able to share these slides with you. These are available, all open access from our Blood Advances journal. But again, these are available to be reviewed and seen as new clinical guidelines. So touch base on the Consortium on Newborn Screening in Africa, or CONSA. I know Professor Nodu in the last webinar spoke about her work on newborn screening in Nigeria. Nigeria is a part of our network, and we'll hear more from Dr. Chirande in just a moment. But I want to make sure to share some broader information on the consortium, including our goal to demonstrate, as noted, the effectiveness of laboratory-based newborn screening and early intervention services in 7 African countries. In West Africa, we have clinical sites in Liberia, Ghana, and Nigeria. And in East Africa, we have clinical sites in Uganda, Kenya, Tanzania, and Zambia. Our goal is to screen 10,000 to 16,000 babies per year in each country, enroll those babies living with sickle cell disease in clinical protocols up to 5 years of age. Those clinical protocols include the early interventions like penicillin, malaria prevention, immunizations, folic acid, general standard care that links well with any country clinical guidelines. We're going to capture the screening and clinical data in the consortium registry for further research. And of course, our goal is to work with national and international partners and organizations like SickleInafrica for the sustainability of these programs so they can exist after ASH's initial investment. So our current CONSA programming, screening is underway at all 7 of our network sites. So we're very excited that 2021, we saw all of our 7 sites be able to begin screening and start data collection. Over 25,000 babies have been screened to this date across all of our 7 country clinical sites, with roughly about 1.5% living with sickle cell disease. And again, those babies have now entered into our clinical protocols, and they will be followed up to the age of 5. And again, we'll be collecting all that research and data for further policy and decision-making. We are also working with stakeholders to ensure sustainability of the programs, as I mentioned, and some of the key areas that we're looking to really focus on, especially in 2022, is on improving hydroxyurea access, providing family education and counseling to families living with children with sickle cell disease, working with governments to institutionalize sickle cell disease screening and care, and advocating at local, national, and global levels for sickle cell disease diagnosis and care as well. So again, we really look forward to the next year working with partners like SickleInafrica and like everyone on this call to find new ways that we can ensure that we're improving care as much as possible, improving access to different therapeutics, educating families and communities on sickle cell disease to remove stigma and improve just general overall education and awareness, and make sure that these programs last, that they can continue on after ASH's initial consortium efforts, as well as ensure that countries can even scale up as well newborn screening throughout the country. Because as I mentioned, while we're trying to screen 10,000 babies per country, many more babies are born in each of the countries mentioned every year. And so we really need to work with governments and other partners to scale up screening and clinical care and do so effectively. Just wanted to share too, as always, we're trying to make sure we're prioritizing sharing, raising education and awareness on newborn screening, as well as care for individuals living with sickle cell disease. So we've had quite a few articles recently dedicated towards newborn screening for sickle cell disease, particularly in Sub-Saharan Africa. Lancet Hematology, Nature, as well as the New York Times have all posted different articles about newborn screening and the benefits. And we're very pleased to see many of our network hematologists who run our national sites were either quoted or part of these articles, including the New York Times. Professor Obiageli Nodu was quoted on her screening work in Abuja. And with that, that was the general overview of the American Society of Hematology, as well as our Consortium on Newborn Screening in Africa. So now I'd love to pass it over to Dr. Chirande to provide a more of an in-depth look at Tanzania. And Dr. Chirande, just let me know when you want me to advance the slide. I'm happy to do so.
Thank you, Andrew. Good morning and good afternoon. As introduced, I'm Dr. Lulu Chirande, and I'm going to present the work of newborn screening in Tanzania on behalf of all our wonderful and dedicated team in Tanzania. Next slide, please. So we estimate that about 11,000 to 14,000 babies are born with sickle cell disease each year in our country, and this varies depending on regions. And sickle cell disease contributes about 7% of overall under 5 deaths in Tanzania. This is largely contributed by either no diagnosis or late diagnosis, and this leads to high morbidity and mortality, particularly in the first 2 years of life. And we know that it has been shown that early diagnosis and comprehensive care can reduce morbidity and mortality for up to 90% for children born with sickle cell diseases. And in Tanzania, pilot studies have been done, and they've shown that newborn screening for sickle cell disease is practical and is actually acceptable. Next slide, please. I would like to discuss newborn screening and early infant diagnosis for sickle cell disease as we interpret it in Tanzania. So we know we do newborn screening for sickle cell disease so that we can identify babies and start intervention. And in general, newborn screening can be done for different conditions, whether fetal, genetic, metabolic, or structural conditions, and with the major aim or purpose of instituting appropriate interventions. For newborn screening, usually you do the screening, you collect the blood the baby, after the baby being born and before they are discharged home. And when we say newborn screening, it is really beyond the sample collection and testing. There are other things that we will discuss later that need to be done for an effective newborn screening program. But so in Tanzania, we really thought about getting babies screened for sickle cell, and we realized that we needed to go beyond delivery, around delivery, that is newborn screening. And that's where we came up with this concept of early infant diagnosis for sickle cell disease. And this is because in our country, in some regions, up to 50% of mothers still deliver at home, so they will not benefit from screening around delivery in hospitals or health centers. And not all health facilities are offering newborn screening for sickle cell disease, and maybe this will not happen in the near future. And even where newborn screening is offered, we have a constraint in human resources. So we have overwhelmed nurses who cannot care for mothers during delivery, and as well as give education on newborn screening, then sign consents and collect blood samples for NBS. But we as well realize that in our country, we have a well-established and effective immunization platform with a very good coverage, where it's up to 90% by the third dose of the first 3 immunization. And these are offered at 6 weeks, 10 weeks, and 12 weeks. So almost every baby born in Tanzania, majority, up to 90%, will visit a health facility for vaccination up to the age of 12 weeks. And we thought we could make use of this to screen for sickle cell disease during vaccination, even though these babies did not have a chance to be screened during delivery. And we really, from the situation where we are, we take this is not late. It is still has a lot of benefits if we can screen these babies by the time they are 3 or 4 months. And we have early infant diagnosis is not a new concept in Tanzania, because this is what has been implemented for some years, quite many years, for HIV. So we have experience, and there are resources that can be shared, and this really add on to sustainability of the program. And another advantage is if we use the immunization platform, we may have a place where we can record the sickle cell disease status of the screened babies. And most parents in Tanzania, when they visit health facilities, whether because the child is sick, they usually carry their RCH card. Next slide. So what we do for either newborn screening, that is screening around the delivery, or for early infant diagnosis, which we do whether in postnatal wards or during immunization clinic, we first offer health education to the mothers or parents. Most of the time it is mothers And this can be done in groups during antenatal visits to give them a general overview in the hospitals where we are doing screening, but also it will be done whether in the labor wards, in waiting rooms. After that is done, one-to-one consenting is done for a mother who is already delivered or a mother who brought a sick neonate in the postnatal wards or during immunizations for well babies. Then when they consent, registration will be done, and this can be done on paper or direct into our electronic system. And then the actual DBS sample collection will be done by trained nurses. And once the DBS cards are dried, we transport this normally once a week from the hospitals where screening is done to the labs where testing is done. Then testing will be done, then we will go to the next phase of result dissemination. I will discuss later how we'll do this. And then for babies who are found to have sickle cell disease, we enroll them into our clinics for comprehensive care and follow-up. Next slide, please. So for the babies that are found to have sickle cell disease, once we reach out to them and they come to the clinic, we now extensively offer health education. We prefer if both mother and father can come, but even if only the mother comes, we do the same. Then we emphasize on routine newborn care, just like other babies without sickle cell disease. And we particularly insist on appropriate breastfeeding. In our country is exclusive breastfeeding for 6 months. And then to complete the routine vaccination that is offered in Tanzania in the immunization program for Tanzania. We don't have yet special or boosters for children with sickle cell disease, but we believe even this one, if completed, will provide quite acceptable protection. We also educate and start babies on folic acid and PNV for infection control. We insist on growth and developmental monitoring, which usually babies will visit the clinic monthly in their routine well baby clinics. And then we will be seeing these babies in our follow-up clinic once every 3 months in the first 2 years. And then these are the specific clinic, and then once every 6 months after they are older than 2 years. We insist on malaria prevention for Tanzania. We are not doing chemoprophylaxis, but we insist on the use of insecticide-treated bed nets, and as well as other means of preventing mosquito bites. Also, we teach the families and healthcare providers on early diagnosis and management of complications so that parents can seek healthcare early when they see any symptoms like fever. And the last bullet is hydroxyurea. So we are working and we are determined to see that the babies that are screened through our program, and later on maybe all babies that will be screened in Tanzania have access to hydroxyurea. And we are fortunate that we have National Health Insurance Fund that has a special package for children below 18 years. And this one offers hydroxyurea. So we are working to provide the health insurance cover to all babies that are tested positive for sickle cell disease, so that by the time they are 1.5 years, that is our ring bell point where we want all of them to be on hydroxyurea. And we will again utilize the immunization platform because 1.5 years, that is 18 months, coincides with the last routine vaccine, which is measles and rubella at 1.5 years in the routine vaccination in Tanzania. Next slide. I would just quickly go through the cancer sites in Tanzania. So we are currently screening in 2 districts, that is Dar es Salaam, where we have 2 centers or hospitals, Temeke Regional Referral Hospital and Yamana Regional Referral Hospital. Then we have 1 center, Bugando Medical Center in Mwanza, where we are also screening babies. And we have a goal of screening at least 10,000 babies yearly for the next 5 years. And we started last year in June. We are screening at birth. That is our component of newborn screening. And for the early infant diagnosis, we are going up to 4 months. because the last vaccine is offered at 10 weeks, so at like 3 months and a half. So at 14 weeks actually. So sample collection is done in the labor wards after delivery, but also in postnatal wards for babies that are brought into these hospitals for any other reason, and also in immunization clinics. Next slide. So this was during the launch of CONSA in Tanzania, which was last year during the World Sickle Cell Day. And this was done in Mwanza, and we have our champion for newborn screening and lead in the Lake Zone, Dr. Emanuela, who was our host. So this was launched about 8 months ago when screening effectively started in Tanzania. It was launched by Professor Makudi, who was the permanent secretary for Ministry of Health. Next slide. So as I said, we have 4 participating hospitals, 2 in Dar es Salaam. So in Dar es Salaam, we target to screen at least 6,000 babies. And then in Bugando to screen 4,000 babies. And we are planning in year 2 to expand, include more hospitals, which is Muhimbili National Hospital and the Aga Khan Hospital in Dar es Salaam, Mnazi Mmoja in Zanzibar, and Bagamoyo in the coastal region. Next slide. And all these hospitals have established sickle cell disease clinics. The ones that we are doing, and even where we are planning to expand, they are established sickle cell clinic where these patients will be followed up. Next slide. So in Dar es Salaam, the laboratory for testing is at Muhimbili University of Health and Allied Sciences. So we transport dried blood spots once a week, but in Bugando Medical Center, the lab is at the same hospital. So there is no transportation of samples. The screening and testing is done at the same center. We use isoelectric focusing for screening and for confirmation as well. So to disseminate results, we call parents of babies who have tested positive for sickle cell disease. And then when we call them, we tell them shortly about the results, and then we schedule their first clinic visits where we will give more health education and start early intervention for that particular baby. And the babies with sickle cell trait, we also call them, and then we schedule a clinic visit if this is necessary. And we decided to call them because from past experience, parents were really confused if you send them a text message. They can't easily distinguish between having a trait and what does that mean and having sickle cell disease. So we call them, and if a parent needs more information, they can visit the clinic. For babies without sickle cell, these are, and they are not carriers of the sickle cell gene, then we send them text messages, and we use bulk text messages, which simplifies our work because these are the bulk of the babies. They don't have sickle cell, so we send them text messages. Next slide. So we are going to look at the results so far. These are the results by first week of January. So we have screened quite more. So by that time, we had screened 4,300 babies, of which about 86% had no sickle cell gene. They had HBAA, and then about 13% they had sickle cell trait, and 1.7% they had sickle cell disease. In our introduction, we remember we had, the range was varying between regions, but so this one is somehow higher than what has been reported so far, but we are at the beginning of our screening. We don't know when we have screened much more babies, what will be the results. And on our second part, which is quite very important, follow up, making sure that babies with sickle cell, we retain them in the clinics and that they get the early intervention. So for Dar es Salaam, we have so far by January, we had 16 babies who had the sickle cell disease, And the 9 of them, we reached them and they have received their results, and they have 7 have started the clinic visits in variable. So we have 3 who have already done their second clinic visits, but we have 3 who are not reachable. I will discuss what are the challenges. And in Bugando, along the lake zone, that's where we have more patients with sickle cell disease, 51. And then 28 babies have been, parents have been reached. And 9 babies have been reached, sorry, and only 2 have so far made their first clinic visits. We will also discuss what are the challenges, and unfortunately 2 died from parents reported that babies have died, and I think we can get some more information from Gando. Next slide. So we have a number of challenges with the newborn screening in the implementation, and maybe more so in the follow-up. We have done newborn screening in the past, but this time we are also doing follow-up and the provision of early intervention for babies. So in tracing up parents, we face challenges. Sometimes their telephone numbers have changed, or it's not reachable, or parents have moved out of the catchment area, so they are quite far either from Dar es Salaam or from Mwanza, so they cannot come for follow-up. We have a plan to link them to nearby hospitals where they can still receive care. And there is some misconception. Some parents, when you tell them their child is sickle cell disease and they are likely to get sick, they don't really believe this because they look at their babies at the moment and their babies are quite well. There are challenges with finance. Sometimes when these parents go to hospitals, there are some costs associated with registration, consultation, medication, and there is also transport. So for this hospital cost, we are going to sort this out by having this baby's health insurance. And for transport, because the babies will not make so many visits for sickle cell clinics, so they will come for the first 2 years, 4 times a year, which we think this is quite manageable. So after I discuss the challenges, but I also would like to share some strengths that we see we have in Tanzania for the program. And number 1, we have a good buy-in by the Ministry of Health. They are very supportive. They are following up. They get monthly report of how many babies we have screened, where we are, what challenges we are facing. So this is a very good, this is an important strength for our program. But also we have collaborating with Sickle Tanzania. So we are essentially one team in the newborn screening and early infant diagnosis for sickle cell disease. And this has enabled or added up on the leadership, administration, and even people who are working for Sickle Tanzania. They are also working for newborn screening. So we have a big team in a way. We also have a good buy-in by the nurses, who they feel that this is an important service for our country. And they are really doing a great job in screening. The number of babies screened in the past, like 3 months, has really increased. We also have strong host institutions where this program is being hosted at Muhimbili University of Health and Allied Sciences, and also at the Bugando Medical Center in the Lake Zone, where we also have a really strong leadership by Dr. Emanuela. So these are some of the strengths that we have in Tanzania. We feel that it will take us far in our dream to make sure that newborn screening and early infant diagnosis is implemented throughout the country. Next slide. So in conclusion, newborn screening and early infant diagnosis and early intervention for sickle cell disease are feasible and acceptable in Tanzania. And so far, the prevalence of sickle cell disease through newborn screening and early infant diagnosis is high at 1.7%. And we are working closely with the Ministry of Health in planning for scale up of newborn screening and early infant diagnosis services in Tanzania. Thank you very much for this.
Thank you, Dr. Chirande. And now I'm going to pass it over to my colleague, Erin Sheek, who's the manager of international programs at ASH as well, who will speak more about our global capacity building programs. Erin.
Thank you, Andrew. I'm Erin Sheek. I'm the manager of international programs at ASH. Next slide, please. I'm going to start us off talking about the visitor training program. This is a program designed to build hematology capacity in low and middle income countries by providing funding for hematologists and hematology-related healthcare professionals to receive up to 12 weeks of training on a specific topic or technique. Training is designed by each applicant individually to address a specific hematology need at their institution and is carried out in the clinic or lab of an ASH member under their supervision and mentorship. It's important to note that applicants do need to find their own mentor. And upon completion of the training program, participants must return to their home institutions to implement their newly acquired knowledge and skills. The program covers visa fees, round-trip airfare, accommodations, and daily living expenses for the duration of the training. The VTP will be opening this year in March after a 2-year COVID hiatus. So we really encourage everyone to learn more about the program and apply. Please visit the web link below or contact me for more information. Next slide, please. The Global Research Award was designed to support future international scientific leaders, increase capacity, nurture global collaboration, and strengthen the relationships between international hematologists and the American Society of Hematology. This program can accommodate a wide array of hematology-related projects, including basic, translational, patient-oriented, and outcomes-based research. ASH is also accepting requests for training at other institutions, pilot studies, collaborative projects, and other proposals for career development. Recipients are selected based on merit, but ASH groups applicants using the UN Human Development Index to ensure that applicants are only competing against others from similarly resourced countries. The application has a 2-step process. The letter of interest will open this March, and this phase is highly competitive. Only about a third of LOI submitters are invited to then submit a full application in January 2023, and the cohort will begin next July. Next slide, please. ASH has partnered with Health Volunteers Overseas, a nonprofit organization dedicated to improving global health through education to provide hematology education and training. HVO currently has 4 hematology sites, 2 in Cambodia, 1 in Peru, and 1 in Tanzania at the Muhimbili National Hospital in Dar es Salaam. ASH member volunteers spend 2 to 4 weeks on site, providing anything from clinical rounds to lab training to lectures. And as the sites have been closed to volunteers for the last 2 years due to COVID, this training has been temporarily moved to virtual lectures and case consultations. It's really a wonderful program. A majority of the volunteers do return to the sites more than once and build really strong relationships with their colleagues there. If you would like to volunteer, or if you think your institution would benefit from receiving volunteers, once it's safe to do so, post-COVID, you can contact HVO via the link here. Next slide, please. And the final global capacity building program that I'm going to share is the International Outreach Initiative. Since 1999, ASH has distributed educational materials free of charge to hospitals and universities in low and middle income countries through the IOI. The goal of this program is to help address hematology related needs in these areas in regards to research, practice, and training. Applicants need to fill out just a brief application, which includes a description of how they will share the materials with others at their institution, as IOI access is intended for shared and not individual use. Materials included in this program range from the ASH SAP, access to the blood journal, and webcasts from recent ASH meetings. It is a very easy application process, and applications are open and processed year-round, so we really encourage all of you to apply. Next slide, please. And that is all the information I have, but I'm happy to answer any questions and provide more information on any of our programs. Thank you.
Great. Well, thank you, Erin, and thank you, Dr. Chirande, so much for presenting. We definitely look forward to any questions we have from the group. As you saw, my colleague Erin's email as well as my emails on this slide, and we can probably add them to the chat box as well with any questions you might have after this presentation. But with that, I will stop sharing my screen and look forward to the questions now.
Thank you so much, Andrew, Erin, and Dr. Chirande. Thanks very much for that interesting presentation. We'll be taking questions now. So you're most welcome to raise your hand, and then I will unmute you. Vicky, you can go first, please. I saw your hand. Please go ahead. You should be able to unmute yourself. It seems like you've got microphone issues. I'm going to mute you for now and then go on to the next person. And following Oladele, I hope I pronounce your name correctly. Oladele, please go ahead.
All right, thank you very much. I'm on now. Yes, good evening, and thanks for the opportunity to be here. My name is Oladele Olatonya from Nigeria. I've looked at the lot of opportunities for training and manpower development presented to us. I want to know, like, who can we contact for more information about this? There was a time I wanted to put an application for ASH visitors program. So I want to be guided on what to do and how to go about it. Like in my center, like in Nigeria now, sickle cell disease is a big problem, and people are trying to find solutions to it. I learned some centers are making efforts to train people on how to implement stem cells bone marrow transplant for this. And there was a news that recently that's something somewhere in Lagos, they are planning to start it. And other issues that can help the care of patients in our country. So regarding this AVT, I would like to get more information and see how one can apply for it in this year's stream. Thank you very much.
I can take that question. Hi, I manage the visitor training program, and I just put my email in the chat. It's esheek@hematology.org.
Okay.
So as I mentioned, the application is going to be opening in late March this year.
Okay.
So that'll be on the ASH website. You'll be able to find it there if you go to the ASH website, hematology.org, and search VTP. So you can find the application there, and you can email me if you have any questions about the application process.
Thank you very much.
You're welcome.
Yeah.
And I see that Vicky has posted the question in the chat. Thank you. Wondering if the Kanza project is storing the blood spots for future research. Great question. So our primary focus is on the public health intervention of screening for sickle cell disease. And as noted, we only receive consent, verbal consent for screening itself. Now, different sites might be doing things a bit differently, and that's something I want to take back and take that question further, because I think that's a great question to ask all of our different sites, because they might have different protocols in place depending on the storage of blood samples. But at the moment, the consent is just for screening for sickle cell disease. And then from there, we then get written consent from the parents if the child with sickle cell disease and entering into our clinical protocol. But thank you for that question. And I think that's something we'll definitely want to be thinking about. Something to share too with Kanza is, while we have our protocols in place and our initial objectives, we look forward to growing with the research and growing with the science. And if there is new needs for further research or analysis, that's something that we can look to and look to our partners like SickleInafrica on to see how best ways we can do that. So definitely open to having that conversation for sure.
Vicky, could you provide context to that question, perhaps? Vicky, can you unmute yourself? Okay, I think she still has issues with the microphone. Okay, we'll move on to the next person. There's a question in it. Okay, Vicky, you want to try again? Okay, we'll move on to the next question. There's a question by Fiona. Is there any specific criteria when choosing the method for newborn screening?
I'd be happy to start, and then maybe Dr. Chirande, I'd happy to hear your thoughts as well. I think with the way that the Kanza program was initiated was with our hematologists, we agreed, to really focus on building the capacity for laboratory-based newborn screening, particularly with Isoelectric focusing. This was decided given how many of the sites that we were working with, particularly Ghana, Uganda, and others were already using IEF machines to do the screening themselves. And we saw it as a benefit to the idea of eventually scaling up is we want to follow other countries as they've scaled up newborn screening and really focus on that laboratory capacity. So we know that, that confirmatory test will be needed at a laboratory site for any sickle cell disease diagnosis. So that's been the primary focus of Kanza is laboratory based. We know that there is also the availability of point of care testing that many sites are piloting or currently using. And we haven't yet moved into that area of point of care. Many of our clinical sites do point of care for different projects or different pilots. But at the moment, Kanza is primarily focused on laboratory-based screening. Again, this can change and adapt as the science changes, as new research is coming out. But at the moment, we really were focusing on building that laboratory capacity with the idea that eventually scaling up could occur to multiple different sites. And the one thing also I'll add to that too is we work closely with Perkin-Elmer, which is the diagnostic firm that helps supply the reagents and consumables, as well as the machines for newborn screening for sickle cell disease. And one area that we want to see, especially with sustainability, is that we know that one blood spot could be screening for multiple different disorders or diseases and congenital hypothyroidism, for example. And so we hope that with building the capacity for newborn screening for sickle cell disease, we're also helping build the capacity for eventual sites to be able to screen for other disorders and such. So that's kind of our thinking at the moment with laboratory-based screening. But Dr. Chirande, I'd love to get your thoughts as well on that, on our current methods for newborn screening.
Thank you, Andrew. I think you have explained well. So the point of care test, like in Tanzania, maybe when we are expanding throughout the country, particularly in villages, and that maybe can be considered as a screening test. And as you correctly said, there are some programs that we are already using that as a screening test. And once somebody is found to have sickle cell, then we send it to the lab for confirmatory. But for the current CONSA project, we are using isoelectric focusing, and as well, because we hope in Tanzania to eventually build a newborn screening program for various conditions, then this is, we build on that very well. So thank you very much. That's all I wanted.
Thanks, Dr. Chirande. Before I go to the next two text questions, quick question for myself. Is there information on the geographical distribution on sickle cell when these kids are screened? And a follow-up question to that, that one is, is there any information on the relationship between the distribution of malaria then versus the distribution of SED? Because as the patients come in or the kids are being born, you know where they're coming from, Mwanza, Uganda, etc. So you know where they're coming from. So is there information on the distribution, and can that be used to relate distribution of malaria to distribution of SED, sickle cell disease?
I'd love to see Dr. Chirande. Do you have any thoughts on that?
Thank you. There is Dr. Emanuela who would like to answer that question. Emanuela.
Okay.
Oh, okay. I will go on. I think she is not with me. So, yes. So in our country, we have actually one thing. Maybe in Tanzania, malaria is almost widespread, but we have areas where. Oh, Emanuela says she cannot unmute herself.
Okay, now I'm allowed.
Okay, so go on, please.
It's true from historically that we understand that malaria was being related with sickle cell disease. And at our zone, seriously, we have malaria. Malaria is very prevalent here. And we have a lot of children up to adolescents who are being admitted to our hospital with severe malaria, and also who are presenting at lower facilities with malaria and get treated. So for that, I can agree and say yes. But these people who, the previous studies also showed that a lot of people who migrated from the Lake Zone Mwanza and went to Dar es Salaam also was found, they were the huge population who was found to have sickle cell disease there. So we can say, yes, malaria has a relationship. Anything?
Yes, so for geographical distribution, number one, yes, in Tanzania, we have some regions where sickle cell is quite prevalent, and some places where sickle cell disease is not that much common. But maybe another thing about Tanzania, there is so much intermarriage. Maybe it's a good thing about Tanzania. There is so much intermarriage, so that geographical location now really does not mean inheritance. So we are so much mixed. So we see sickle cell from areas where in the past people thought this tribe don't have sickle cell. But surely we have some regions where sickle cell disease is very prevalent. Some we are already there, like in Mwanza, but some places we are not, like in Zanzibar. So and we are planning to go there in our expansion program.
Thanks, Dr. Chirande and Emanuela. Just from the chat box, Olaitan asks, I'm not sure whether his question was answered, which lab methods are used in screening for these conditions? And I think he refers to the what Andrew was talking about, the fact that a single blood spot would be able to be the test for different conditions. So the question is, which lab methods are used in screening for these conditions? Tandem mass spectrometry?
Testing for sickle cell disease?
Olaitan, let me unmute, send you a request to unmute you, and then if you can clarify your question. Yeah,
yes, testing. Yeah, sure, testing. Thank you very much for letting me speak. So yeah, for testing for STD, I was just concerned like the specific lab protocols you use in screening.
So in Tanzania, we are doing isoelectric focusing both for first test and the confirmatory test. We are using the same test for so the both two time points that we are screening and when we are confirming the sickle cell status of the. I don't know if I exactly answered you. And yes, we have protocols that are followed in the lab. Do quality assurance, which sponsor is very keen on that. So I'm not sure if I correctly respond. For other diseases, we are not screening yet.
Okay, he says that you've answered this question. Thank you very much. Patrick Alibu is asking, how was quality control handled during sample collection, DBS transportation, and then testing using isoelectric focusing? Alibu is from Makerere University in Uganda.
So I'd be happy to kind of share some of our broader Kanza protocols. And then Dr. Chirande, if you want to share a bit more of Tanzania. So when it comes to DBS collection and transportation, we definitely have worked with hematologists globally, as well as hematologists who've implemented these programs in low-income settings for a number of years to share their best practices, ensuring the best collection as well as transport. I know Dr. Chirande, I think recently just had a whole training with nurses on on sample collection. And so I think we've also been making sure we're doing regular trainings with clinical staff on how to best collect samples from newborns and then and storage and transportation. When it comes to laboratory, we have several protocols in place to ensure that there is the oversight and support needed for laboratories as they're conducting screening. So with Perk and Elmer, as mentioned, they provide us with technical expertise and best being able to train laboratory staff on the use of the MyGel Isoelectric focusing machine. So they provide that in-depth training either in person or virtual. With COVID-19, it's been virtual. We then also do regular photo samples of the gels that can be shared with different hematologists and laboratory professionals around the world who can share their expertise on the correct labeling of correct labeling. And then finally, through our data collection too, we have processes in place to make sure that we're monitoring as data is entered into our central database. We're monitoring to make sure that data is cleaned regularly and that any anomalies that might be occurring can be addressed by the staff on site. So we have numerous processes in place to make sure everything's working as best as possible. But Dr. Chirande, would you like to add anything based on your experience?
So for sample collection, we have trained the nurses. And so when they bring the DBS cards to the lab, they are inspected, and only those that meet the quality, they are processed. And we had a media review and report Monday this week for the nurses, where we went through all issues of data, of DBS collection, but also we have regular feedback. So we are in contact almost every week. There are people who are going from Muhimbili to the sites. So we have regular feedback as ongoing. Sometimes we get new nurses, again, we train them, who have joined the hospitals, we train them. So far, we don't have really problems with quality of DBS collection. Most of it, I would say over 90%, they are done very well and they are processed. Thank you.
Thanks, Dr. Chirande. Just as a follow-up, Vicky clarifies and says that she agrees with Olaitan about the consent. The concept project could easily be the basis of a great longitudinal study that's from birth, and that I think that speaks to consent and the long-term use of the data obtained from these spots. Nyasa, I hope I pronounced your name right. Nyasa Mapira is asking, is the program only screening for the presence or absence of SCD, or further genotyping for the type of SCD?
I'll just add, so primarily our focus is, because it's meant to be more of a public health intervention, the presence or absence of sickle cell disease or sickle cell trait. We do have some genotyping that occurs and some level of variant screening that can occur, but we are collecting that data for sure on different genotypes that can be found depending on the capacity of our sites. But our primary focus is on the presence or absence of sickle cell disease.
Thanks, Andrew. Fiona is asking, is CONSA open to the partnering with other partners in addition to Perk and Elmer in support of lab-based screening, for newborn screening?
Yes, absolutely. So we know that, as I mentioned, CONSA, our targets are 10,000 babies per year in each country screen. That's by no means are we actually going to reach every single child that's being born every year in each country. And so we definitely need to work with partners like Perk and Elmer. We've definitely been in conversation. I have a formal partnership with Novartis as well, who has been doing a lot of efforts in Sub-Saharan Africa. And so we're definitely always looking for different organizations who are expanding their work and supporting sickle cell disease diagnosis and care. So happy to have any conversation, absolutely, on ways that we could work together for sure. And just a note with that, I know it's kind of linked to another question on, are we looking at additional sites? At the moment, we aren't looking to expand from our clinical sites that we currently have in our countries. That would have to be done, any sort of expansion would have to be done by and led by the national coordinator, like Dr. Chirande, or the principal investigator, and really being done in collaboration with governments and so forth, because we know that, we don't want to see this ASH project that we're supporting expand so much, but then not be able to continue. And so we are taking a really fine look at how best we can expand in different ways, but at the same time respect that we want to do this in collaboration with local stakeholders, local governments that could continue these efforts for years to come. But again, happy to have those conversations.
So Andrew, so you're referring to the question by Oladele? It's Oladele.
Yes, correct.
Okay, cool. Oladele, does that answer your question? I've asked you to unmute. Does that answer your question? And is that clear for you?
Yes, yes, I didn't get. Could you please kindly go by it again? I didn't quite get the message clear, but please, could you kindly please repeat that again?
Sure.
Sorry. Yes.
So let me make sure I see your question. So in Nigeria,
yes,
our 2 clinical sites that we have are the Federal Capital Territory, led by the University of Abuja Teaching Hospital.
Yes.
And then in Kaduna State, we have a clinical site as well.
Okay.
So those are the 2 primary focus. In order for us to expand, we have to do that under the leadership of the national coordinator. For Nigeria, it's Professor Obiageli Nodu.
Yes.
She has already been working to find ways to do that, and we want to do that in collaboration with local governments. Again, because the finances that ASH is used to support newborn screening are finite, and we need to look to our local partners to really be a part of the efforts to expand services as much as possible. So I would say expansion is kind of under the leadership of our national coordinator, but we're always looking to discuss more ways that we can work with other partners to increase newborn screening.
Okay, thank you very much. So I will look forward to having it expanded to the southwest, toward the southern part of the country. You know, the 2 centers that are active now, domicile in the north, and we quite have a lot of challenges going through newborn screening in Nigeria. And like you said, we'll look forward to the program getting extended to the southern part of the country. Thank you very much.
I know it's at the hour.
Thank you very.
And I just want to make sure,
Yes,
Dr. Chirande, I know that you had some requirements to attend to. I'm happy to stay on a bit longer to answer any general questions on Kanza. Just to note again, I'm not a medical doctor, so I can't answer more medical specific questions, but Dr. Chirande, I didn't know if you might have had to leave now to get back to your duties.
Thank you very much, Andrew, and thank you for this opportunity, and thank you everybody for listening. Good day.
Thank you so much, Dr. Chirande. Andrew, thank you very much. Yeah, like you said, we come to the top of the hour. What I'm going to do, I think there are 2 questions left, so I think we can address those and then call this meeting to a close. So from Patrick Alibu again, any information? I'm gonna post both of them at the same time. Is there any information on the specificity and sensitivity of the Isoelectric focusing machine that directed it being considered? That's being considered for screening and confirmation. I think Prof. Chirande would probably be good to answer that question. And then the other one from Dennis Kazozi, is PCR RFLP with DDEL used in SCD diagnosis confirmation? So those 2 questions. And then the last one would be, Fiona was asking, could you please share your email address if possible to take a partnership discussion further? So if you could address those 2 questions on the specificity and sensitivity of isoelectric focusing, and then also on PCR, whether PCR RFLP with DDEL is used in SCD diagnosis. And then we'll call this meeting to a close. Thanks, Andrew.
So I think probably the easiest way to answer both questions would be just to share from PerkinElmer their MyGel system specifications. So we use the MyGel isoelectric focusing from PerkinElmer as our main tool for screening and diagnostics. And so I think the best approach would be to look at their website and look at their resources on that software. This was used by numerous of our sites that have been screening for a few years now, including in Ghana, as well as in Uganda. This is kind of why the decision was made on isoelectric focusing. We also know, unlike HPLC, which is a bit more expensive, IEF was seen as the best use of the resources that we had. So there was that sort of decision made as well. But I would say I'm happy to share the information I received from PerkinElmer on the MyGel system and those specific specifications, and happy to kind of have follow-up conversation on that as well.
Thanks, Andrew. So is this the MIGELE system, correct?
Yes, that is correct. I just typed it into the chat
that's
as
correct,
well.
yeah. Absolutely, yeah. So Thank you very much, Andrew, Erin, and Dr. Chirande in absence. Thank you very much for everybody attending. So yeah, please continue liaising with the members of ASH regarding any further questions. What I am going to do is I'm going to paste into the text box the link for the YouTube channel and playlist for the webinar series. So if you have missed any part of this session, please check tomorrow for the video of this. You should be able to download it, and if you want to share this link with somebody who you think may be interested in the content, please feel free to do that. With that, I would like to thank all of you for attending, and thank you, the presenters, for sticking to time. Thank you very much, and all the best to everybody. Goodbye.
Thank you, everyone. Have a great rest of your day.
Thanks, Andrew.